much. That was good military order. But we've got the band back together for our discussion this morning. The title of this panel discussion is "I Used to Be a Wounded Warrior," and we talked about that earlier. I mentioned that earlier, how that phrase affected me. And after a week of the science of military medicine, now we're going to talk about the personal journeys, at least in part through the eyes of people who have made the journey from the other end of the stethoscope. And I will do my part by introducing Walter Greenhalgh, Captain Medical Corps Navy, who's the director of the National Intrepid Center of Excellence, the NICO, at Walter Reed. He will chair the panel, and Captain Greenhalgh will introduce his panelists. Thank you, sir.
Well, thank you very much, Admiral Cowan. Pleasure to be here. So good morning, everybody, ladies and gentlemen, generals, flag officers, colleagues. I'm, as Admiral Cowan said, Walt Greenhalgh. I direct the NICO, the National Intrepid Center of Excellence, right here in the nation's capital. You'll hear a little bit more about what I do there and what our wonderful facility does and my wonderful colleagues do to help take care of injured service members. But in the meantime, I just want to let you know I have the privilege of moderating this morning's panel discussion titled "I Used to Be a Wounded Warrior." And I will say that when Vice Admiral Cowan asked me to do this, I had a couple of thoughts. The first is, what do I know about being a wounded warrior? Obviously, being engaged in the care of these fine Americans is very formative experience in my life and my career, as is with my colleagues. But what I bring to a discussion like this. But then, of course, my second thought is I'm not going to let Admiral Cowan down. He's a formidable force and a mentor to many naval officers, having sort of put the Navy on a wartime, Navy Medical Corps on a wartime footing right after 9/11. And so I will proceed. And then, of course, came to the realization it's a panel discussion, and so I get to choose the subject matter experts who will really help guide this discussion. And so as Admiral Cowan said, I'm chairing this discussion, but my role is to speak as little as possible and let these fine colleagues of mine kind of do most of the talking. So what I'd like to do real quick is just make some brief introductions, and then we'll kind of transition to talk show host venue here and join my colleagues over at the table. But first, what I'd like to do is introduce my fellow panelists here. Starting to my immediate right here is Dr. Paul Pasquina, Colonel, United States Army, retired, and he's currently the Chief of the Department of Rehabilitation at Walter Reed National Military Medical Center. He's professor and chair of Department of Rehab Medicine, F. Edward Ebert School of Medicine, Uniformed Services, University of the Health Sciences, again right here in Bethesda. And he'll bring that unique perspective as somebody who was sort of at the pointy end of the spear taking care of these injured service members right off the battlefield at Walter Reed Bethesda during the last 15 years of war. Next to him is Mr. Larry Miller. And Larry Miller is a retired U.S. Navy commander, a physician assistant, a great friend and colleague who's actually currently now the TBI lead down at the Physical Medicine and Rehabilitation Department of the James A. Haley Veterans Hospital in Tampa, Florida. And Mr. Miller brings some additional perspective to this, having been, again, on the active duty side, as well as now working through the VA. Also having worked with my predecessors in standing up the program that was to become the National Intrepid Center of Excellence, a program which others have, sort of developed from that kind of model as well. So I'm very interested in hearing his perspective as that sort of link from military health system to Veterans Administration health system, and sometimes back again to the MHS. After Mr. Miller is somebody that I don't think needs much introduction, but Colonel retired Greg Gadson, star of film and screen, but a highly decorated U.S. military officer, Army officer, film star, motivational speaker, but has obviously transited that pathway of operational injured service member through the pipeway, made a successful return to the active duty side and transitioned to the civilian side. And so I think he'll bring a very unique perspective from that idea. The other thing that I find important is, as we'll talk about when I describe my facility, the NICO, is this idea of sort of satellite facilities around the country, and he was the commanding officer at Fort Belvoir when we actually opened up, and he actually cut the ribbon on the first satellite facility in the country down at Fort Belvoir several years ago. And so, again, his perspective on, or his thoughts on sort of this network of a traumatic brain care pathway of care, I think will be important as well. And then finally, last but not least, another good friend and colleague, Dr. Rory Cooper. And Dr. Cooper is the chair and distinguished professor of the Department of Rehabilitation Science and Technology and professor of bioengineering, physical medicine and rehab, and orthopedic surgery at the University of Pittsburgh. And he's also founding director and the Veterans Administration Senior Research Career Scientist of the Human Engineering and Research Laboratory, or HURL, a research and development center of excellence at Pittsburgh. And I think Dr. Cooper brings, again, some very unique perspectives here, having been a veteran himself, injured service member, as well as somebody who's really, changed the paradigm as far as rehabilitation care and the science of rehabilitation, turned it into a real science. Also brings that perspective of bridging the gap between sort of the civilian side, the academic side, the VA side, and then also through close collaboration with colleagues like Dr. Pasquina at Walter Reed, so that connection to the DoD as well. And it's no surprise that these gentlemen sort of know each other, both professionally and as patients through their careers. And I think they will bring a very interesting and unique perspective to the discussion we're going to have here today. So I'm going to transition to talk show host. Can you still hear me? And are my slides up? There we go. So what we're going to do, each of us is going to sort of introduce our own little areas of expertise, what we do. Hopefully 5-6 minutes, no more than 10, Paul. And then what I'd really like to do is go down the line, and we'll finish off with Colonel Gadson kind of describing, sort of putting this all together from the perspective of the service member who transited this pathway. So as was described at the beginning of the introductions there, my name, I'm Walt Greenhalgh. I'm the director for the National Intrepid Center of Excellence. Some of you may have visited. If you've been to Walter Reed National Military Medical Center in the last 5 years or so, you've probably at least seen the building. And hopefully some of you have had the opportunity to come in and visit with us there. So the NICO is an instrument of hope, healing, discovery, and learning. And this first slide kind of shows the NICO building there on the left, with Walter Reed National Military Medical Center on the right. Not to show that they're two separate entities, but they're both included to describe them as one and the same. NICO is a directorate of the Walter Reed National Military Medical Center, which wasn't always the case. When we opened our doors, we were sort of a separate entity sharing a campus with Walter Reed. About 2 years ago, we initiated a process of integrating into the directorate or command structure of Walter Reed, sort of really to unify traumatic brain injury care continuum on the campus. If we're talking about a national network, it made sense to at least unify that on the campus. And Dr. Pasquina and I and several other colleagues worked real hard to get that going. And it's been a very successful integration. I'm remiss in actually not including one further picture on this slide, which is Uniformed Services University, with whom we also have a great collaboration from the research perspective. So as a clinical research institute, we have a pretty broad portfolio of traumatic brain injury research with which we have a great collaboration with Uniformed Services University. Our mission, we improve the lives of patients and families impacted by traumatic brain injury through excellence and innovation. And our vision, we aim to be a global leader in TBI care research and education, maybe a lofty vision, but not so much when you think of the types of people who reach out to Walter Reed National Military Medical Center to see what we do in our flagship of military medicine. We have visitors from around the globe, and just in the last 6 weeks, I think we've had half a dozen different countries represented. In 2 weeks, we have 4 additional countries coming to see what we do at Walter Reed, and they take those lessons back with them to wherever they come, and have reached out to us as they try and establish programs similar to what we have, not just at the NICO, but through the Military Advanced Training Center, the Rehabilitation Center of Excellence that Dr. Pasquina will talk a little bit more about. And our guiding principles, as is the case across the campus, is excellence, innovation, compassion, honor, and collaboration. The NICO itself got its start. I'm sure probably some of you have heard this story before, but the Intrepid Fallen Heroes Fund, a philanthropic organization out of New York City, with the Fisher family name attached to it, have been strong supporters of the military since the early 80s. And in 2000, the Intrepid Fallen Heroes Fund kind of stepped in, and at the beginning of the conflict, said that they would try and provide some more brick and mortar support to the service members. And as we had this influx of amputees and burn care patients early on in the war, said, well, we'll stand up a center of excellence for amputee and limb issues for the injured service members. And so in 2007, they opened the Center for the Intrepid, the CFI. And the way they did that was to collect funds from the American people and build this nearly $60 million facility down at Brooke Army Medical Center, a very successful facility. Based on that model and the success of that model, again, the Intrepid Fallen Heroes Fund said, well, now that we recognize traumatic brain injury and psychological health concerns like PTSD as a significant signature injury of this war, maybe not as well seen, but certainly very significant, they again stepped in and said, well, we will collect the funds from the American people, in this case to the tune of about $65 million, and build a similar type facility on the campus of Walter Reed Bethesda to be a center of excellence for the care, treatment, and study of service members affected by traumatic brain injury and psychological health concerns. We opened our doors in 2010 and really haven't looked back since then. The success of that model, again, sort of translated into additional effort where the Intrepid Fallen Heroes Fund would build satellite facilities around the country. And we call them satellites, but they're really their own sort of standalone programs that share a lot with the program that we have at the NICO facility at Walter Reed. Currently, 5 of these facilities are now open and functioning and doing great work. A 6th one has broken ground. There'll eventually be 9. And at the end of the deck here, I'll show sort of a map of where these are scattered across the country. Why is this important? Why is a program like the NICO's, an interdisciplinary approach to care, important? Well, if you pick a disease process, any disease process, cancer, chronic pain, multiple sclerosis, you'll find that there's a comorbidity associated with many of these conditions. And so it's imperative that you not just have a multidisciplinary approach to care, but that you have an interdisciplinary approach to care to address these comorbidities. In the case of traumatic brain injury and psychological health concerns, sometimes it's difficult to discern what a symptom is due to. Is it the traumatic brain injury history or psychological health PTS issue? And as the comorbid symptoms oftentimes cross over, it's really kind of a symptoms-based approach to care and not a diagnosis-based approach to care. The NICO has several different clinical programs in its portfolio. Again, as we integrated traumatic brain injury care across the campus. Our legacy sort of 4-week intensive outpatient program is what we're sort of well known for, but integration certainly brought together legacy programs that long preceded the establishment of NICO in the main part of the hospital, as well as programs started at the Walter Reed Army Hospital. So we do have, in addition to our outpatient program, our intensive outpatient program, we have an inpatient mission as well. Obviously very important over these last few weeks, always important, but brought back to the forefront these last few weeks as a new influx of injured from downrange come into the hospital. Long-term outpatient follow-up we do as well, and then kind of targeted evaluations through different services within the NICO directorate, rehab, art therapy, the neuroimaging, you name it. This is just a snapshot of some of the clinical capabilities in this one facility, and it's not to suggest that we have 22 different clinicians. We have some very talented clinicians who themselves practice 3 or 4 different modalities on this list, but a very talented group of people that work in that facility. And this is kind of what it's all about. It's that sort of patient-centered, holistic approach, and it's, again, by no accident that we have the patient and a family included there as well, because we have a very robust family program incorporated into our program. And then we call this kind of the wheel. You'll see that all these folks are really kind of targeting taking care of that patient and the family. And then just a quick run through. This is just sort of some of the outpatient neurorehabilitation that we support across the campus. Brain Fitness Center is a unique capability from the NICO Directorate. It's sort of neurocognitive rehabilitation that is not just beneficial to those with traumatic brain injury, but also other forms of acquired brain injury, to include chemotherapy, neurocognitive deficits, and so we're working closely with the Merthyr Cancer Center to provide this service to some of our chemotherapy patients. Again, I sort of touched on the inpatient services. Sometimes it's not a very robust service, but in the last few weeks it's been very robust, and so having that capability at the ready is very important. Everything that we do in our directorate, it contributes to a research mission, and again, as integration brought us all together, we accumulated a portfolio of about 22 to 23 research protocols, broken into 3 main buckets: treatment and evaluation, imaging and measurement, and then longitudinal assessment. And then, of course, you can't do research without collaboration, and so we do have a very robust collaborative network not just through NICO, but through Walter Reed, through Uniformed Services University, both federal, private, and academic. And then I alluded to briefly before the Intrepid Spirits. This is sort of a snapshot of where they will be. I'll admit that there's a bit of an East Coast preponderance of where they are now, but as you can see, the country will be covered. And that will provide essentially 10 sites to include the NICO for this new NICO Intrepid Spirit network of care that we hope, and as we see, is sort of developing some pretty good care for our traumatic brain injured patients. And then this is just a kind of family portrait, if you will, of some of the Intrepid Spirits. Very similar in look, and I was asked last night, are they similar in what they offer? And understanding that a service member injured at Fort Bragg is probably different than the way a service member injures themselves at Fort Belvoir, or the type of patients that they would see in Southern California at Camp Pendleton. So there are some unique capabilities for the local demand. Nevertheless, there are some commonalities as well, and it sort of came. It was very apparent just 2 months ago when all of the leadership from the Intrepid Spirits, both those that are built and yet to be built, came together to visit us and spend a week with us at NICO, Walter Reed Bethesda, to discuss best practices, standardized care, standardized data collection, standardized analysis, and standardized outcome metrics as we move forward and, as I said, build these last 4 Intrepid Spirits. And so it's a terrific network that is feeding off each other, and I think has reached critical mass to really be a formative force in traumatic brain injury pathway of care in the military health system and the VA and in the U.S. in general.
Great, thanks. That's a pretty slide.
Pause for commercial break.
Yeah, so again, I'm Paul Pasquina, the chair of Rehabilitation Medicine at the Uniformed Services University and chief of rehab at Walter Reed. I think you all, I don't want to say stuck with us, but we have 2 hours of a panel discussion here. And our hope is that some of the topics that we bring in will help stimulate further discussion. We've got a very diverse panel and obviously a very diverse audience. So rather than talk about all the issues with rehabilitation, I'd like to kind of discuss some ideas that do create some challenges to successful community reintegration. Here's the disclaimer, and I think everybody knows this, but it's nice to reflect back a little bit. Since September 11th, the military has deployed over 2.5 service members overseas. Over 50,000 of those folks deployed have been, significantly wounded. The new weapon of our enemy is improvised explosive devices or blast injuries. We are achieving historic survival rates, but as people know, surviving in the battlefield is just the first step. Ultimately, what we really want is folks reintegrating back into their communities, back into active duty, and back into their families. And we need to be thinking along that continuum of care from point of injury all the way back through the rest of their life. And so what I'd like to do is talk a little bit about some of the challenges with doing that, and then how we can work with it from the DoD and VA with our TRICARE and community partners to do that. With blast injuries, we see a very unique pattern of injuries, particularly those that are dismounted, hit with a blast explosive device, losing both lower limbs, significant injuries to the upper limbs, and then you can just imagine being that close to a blast, how frequent the comorbid risk of developing traumatic brain injury, maybe some visual impairment, hearing impairment, and then I would argue that you can't be exposed to that type of trauma and then not also experience some psychological trauma. I think I pressed the, did the slide stick? Hello? Can you go to the next slide? Is that possible? There we go. Did I have a slide before this? And a slide before that? And a slide before that? There we go. Okay, next slide. Sorry. here. I think putting this in perspective too, recognize that most of the folks that we send overseas are under the age of 35. So if they are injured, they're going to be living with these injuries for the next 20, 30, 40, 50 years. And so we need to be committed not just for the short term, but for the long term in terms of helping them. Go to the next slide. We have very good data from World War I, World War II, Vietnam, and even from the first Gulf War, that we know folks that suffer these types of injuries, whether they be amputation, where most of the data is, or trauma in general, they are at risk for chronic pain. There's a, whether it be phantom limb pain, residual limb pain, constant skin breakdown and problems with infection, advanced arthritis in the remaining joints, osteopenia. I'll talk a little bit about the long-term effects of brain injury, cardiovascular disease. Many folks don't necessarily recognize this, but your risk of dying after limb loss from a cardiovascular injury is about fourfold that of your age-match controlled peer. Deconditioning, obesity, hyperlipidemia, diabetes. So these are all significant health and wellness issues that we need to recognize are going to be significant challenges for our injured service members. We have some early data. Actually, this was a study done at the Uniformed Services University by one of our colleagues, Dr. Pollard and his group. Soldier's heart has been written about for centuries, but now we're able to look at, with advanced technology, maybe what triggers some gene reaction, some gene activity that might set folks up for increased risk, cardiovascular disease, diabetes, hyperlipidemia. So we can get at the science of this. But if we are able to identify those folks that are higher at risk, how are we going to treat them? Not just one time or two times, but over their life to help prevent some of these long-term complications. Long-term complications of traumatic brain injury. We've all read in the press from some high-profile NFL athletes. What happens with repeated concussion? What happens with repeated traumatic brain injury? Is this what we can expect for our service members as they age with brain injury, whether it be blast or otherwise? Are they going to suffer from the effects of chronic traumatic encephalopathy? How are we going to identify those folks, and how are we going to mitigate those risks? We have some early data looking at folks from Vietnam and OIF and OIF that they are at significant risk for arthritis, traumatic brain injury, depression, PTSD. So these are real issues. They're not just something in a textbook. We know that the biomechanical effects after losing one limb or having disability in multiple limbs can cause on the musculoskeletal system. We have advanced technology, but that technology is not at the point now that it reproduces perfect gait and perfect motion. It does do some, huge benefits though. So some of the advances in technology, it's very difficult, and many people with bilateral transfemoral amputations don't even walk, much less have the confidence in their prosthetic limbs to walk through a busy parking lot with their child on their shoulders. Can you play this video? So this is a video, this is one person in the world with one arm that exists in the world with an osseointegrated prosthesis. So you can see this individual. This prosthetic or robotic arm is actually directly attached to this individual's skeleton. And he is using a multiple degree of freedom robotic arm. Again, there's only one person in the world that can do this. But just to show you that folks are working at some of this technology to help mitigate some of these risks. And we've learned significant lessons over the years about how to enhance our programs, which I don't really want to spend a lot of time on, because I'd really, rather than the positive lessons that we've learned, and the success that we've had in returning folks to active duty, I think it's important for this discussion to talk about some of the gap areas and things that we really need improvement on. Substance abuse and misuse. We need to do a better job at taking care of our service members and making sure that when they go home, they're not using substances to help control their pain or help control their mental health challenges. All too often we use our pharmaceuticals to combat some of these challenges, and I think we can do a better job at identifying those folks at risk and help mitigate some of those challenges. We really lack any long-term outcome vehicle to see how our service members are doing as they move out of active duty into the VA system, maybe back into the TRICARE system. We really lack a national longitudinal outcome strategy for looking at those folks and identifying those folks that may be challenged as they move back to their communities. We really need to be more engaged in a wellness program. We talk about helping service members meet their wellness needs, but do we do this and how effective are we doing that? Are we emphasizing diet and exercise, mindfulness, tobacco cessation, all these things that we know will help them in the long run? How well are we doing it? And then lastly, I'd like to talk about the caregivers. Caregivers and families are a significant portion of our DoD family. In fact, if you look at it, most of the children of our soldiers will be the future military. And how are we treating those families? We've seen through the research that we've done that many of these social networks are falling apart as folks leave institutions like Walter Reed and get back to their hometowns. How can we avoid social isolation? How can we help mitigate some of the stress that families encounter? How can we help promote better parenting skills and supporting some of the role changes, encourage and incentivize our injured service members to get back to employment, and recognize that depression, even of caregivers, is about 54 to 71%. So of the caregivers of our service members, we can anticipate that about 3/4 of them will suffer from depression, and we need to be able to mitigate some of those challenges. So with that,
thank you, Dr. Pasquina. If I could, I have Dr. Cooper as the next one, and I think that's the way it's teed up in the slide deck. So I think we have a video for Dr. Cooper.
Yes, well, thank you for coming this morning and for offering me this opportunity. I'd like to, pick up on what Paul said too. One of the major transitions that we made was the concept of integrating adaptive sports into the rehabilitation process. And what I think that I found rather fascinating is that how readily our wounded service members adopted to that, and how aggressive they were at really setting higher standards for all of the providers for them to achieve. So it really wasn't about independent living skills, but being able to do the Army 10-miler or the Marine Corps Marathon, or getting back to work, riding their bike with their family, some of the wonderful programs that came about as well. So adaptive reconditioning, you mentioned that has been important for both family and the service members. What I'd like to say too a little bit is that the VA has been engaged in that very actively as well, with the Veterans Wheelchair Games and Winter Sports Clinic and Summer Sports Clinic and Creative Arts Festival and Golf Tee Classic as well. I'm now going to just show, if you will, just show a little video, describe some of my involvement. In the United States alone, 1 in 7 people that has a disability of some kind that impairs their activities of daily living. And technology has tremendous potential for improving the lives of people with disabilities. I was serving in the Army as a sergeant in Europe when I was injured, and I came home with a spinal cord injury and had to use a wheelchair. There was like an 80-pound behemoth that I could hardly get in the car. I realized that there were a tremendous need for improving technology, improving the environment, and improving perceptions of people with disabilities. When the opportunity arose to work with the University of Pittsburgh and the VA Pittsburgh healthcare system, it was natural that we'd start HURL.
The laboratory, our mission is to improve the quality of life for people with disabilities through advanced research or engineering, get people more integrated into the community and to make them more independent. We do this through some of our programs that we have here, whether it's educational or research or outreach.
We started out as a wheelchair lab doing sort of manual wheelchair work and have expanded over the years to include brain-computer interfaces, robotics, virtual reality, cognitive aids, home modifications, and training.
The system that you see behind me, that's called the CAREN system, or the computer-assisted rehab environment. We work with people who have gotten prosthetic limbs. So in terms of how are they adapting to a newer technology. One of the latest technologies that's come out from University of Pittsburgh is the brain-computer interface, a robotic arm directly getting signals from the brain. So we're trying to see if we can get that technology, use it to drive wheelchairs much more efficiently, not just control left or right.
We have a machine shop where we can basically fabricate anything mechanically or electronically that we wish. What's kind of unique is not too many university programs allow you to do the design, but also do the fabrication and take you through all of those steps.
This is our robotics lab. Everything you see here has something to do with robotics.
We developed this called the Strong Arm, which is a robotic-assisted transfer device. This mounts to the wheelchair, folds up behind them.
We've developed ones mainly to replace upper extremity function for people, and then we're working on ones that can actually lift the person.
I think 10 years down the line will be something you would see used quite frequently and have tremendous impact on people's lives.
I was in the United States Marine Corps for 15 years. I was medically retired after being injured in Iraq.
Many of our people in HURL are themselves veterans, and many of them work clinically in the VA.
Press that bottom button until that says set.
I ended up here through an internship program called Elevate, and this program was designed for people to transition from the military back into academics who have any type of interest in assistive technology, engineering, and research.
Since our inception, we wanted to include veterans with disabilities in HURL as employees, as trainees, to reach out to them.
The experience I had transitioning through the programs here and the work that we do here really put a passion and fire inside of me to give back to the community, not only the veteran community, but others with disabilities like myself.
Our research is continuously evolving as we can adopt new technologies and information from other fields of science that have influenced us. The end goal for us is full autonomy and full participation in society as equal partners and respect for people with disabilities. So I think we have a lifetime's worth of work ahead of us.
We taught from day one, we're not doing anything for charity. We're helping people to be themselves so that they can do better. You're not taking care of people, you're helping people take care of themselves.
Thank you, Dr. Cooper.
Just so you made a cameo.
Mr. Miller from Tampa VA will be next.
Thank you. Admirals, generals, distinguished visitors, Captain, thank you for the opportunity for me to come and speak with you today on the James A. Haley PrEP program, which stands for Post-Deployment Rehabilitation Evaluation Program. We are an inpatient program. We're a 3-week evaluation program, very similar to NICO, and they've been doing this down there before I joined them for about 8 years. Recently, we expanded the program to include a treatment arm of the program, which we feel makes us very different and greatly improves and treats what we diagnose at NICO. And Captain, we've had a great relationship with NICO over the years, and we're synergistic. We share patients, we share data, we share information, and I think that's a fantastic way to prove that we are doing DoD-VA collaboration in an effective format. We do treat mild to moderate TBI. We also, as you'll see, we integrate in the mental health portion significantly. Just like at the NICO, we are a multidisciplinary center. So we have all of the disciplinary areas evaluate these patients on the 3-week evaluation inpatient program. We also are able to get all of our diagnostic studies done during that time. And usually at the end of the 2nd week, we sit down and we talk amongst ourselves, and we talk with the patients, and then we develop a care plan for the patient. If they have the ability to stay for our treatment on program, we offer that, or we offer a very complete discharge summary where they can go and get this care elsewhere at home. I will say that 75% of the patients that we have, because of our close proximity to MacDill Air Force Base and the Special Operations Command, about 75% of our patients there are active duty Special Forces patients. We use the integrated team approach, one-stop shop. We meet every Thursday morning and discuss each patient's progress, and we come up with a weekly care plan for that patient. We then sit the patient down and discuss with them their care for the next week coming up and any concerns or problems that they may be having during that time. This is not a one program fits everybody. This is a very flexible program, so we are very flexible with the patients and adapt what we do to the patient. We find that consistent education is important, that the team gets together and that we all agree on a care plan and a direction that this patient is going to go in. They're coming to us thinking, when I'm not sure if I'm broken, I don't know if I'm crazy, I don't know what's going on with me, but something's wrong. And so when we sit down and we consistently go through their diagnoses and their care plans, they understand much better and they calm down, and it allows us to take care of them better. So the PrEP program has an extended treatment arm. One of the things that I think that we may be just catching up now on is we had the signature injuries of the war being PTSD and TBI, but much of what we see are musculoskeletal problems, which almost every person that comes in has musculoskeletal problems and pain and sleep issues, where almost every one of our patients has significant sleep problems. And we keep our sleep program very busy there, trying to take care of all these patients. So in the initial phase of the program, we're a 3-week evaluation program, and then we could offer them up to 12 or 14 additional weeks. With a lot of these folks being special ops and active duty, it's much easier for us to talk to the commands, and the commands giving approval for them to stay in the treatment on program. With veterans that are out and employed, it's much more difficult for them to get the time off to stay in the treatment arm. And in that case, we have a very robust outpatient program, very similar to what NICO has been doing. So we have great outcomes. You don't get better than 100%. When they leave at the end of the treatment on program, 100% of the people feel that they're emotionally functioning better, that they're sleeping better, that their cognitive abilities are better, and their physical abilities are better. So we treat all of this during that time, and when they leave, 100% of them feel that they definitely have improved. So we're not your dad's VA anymore. So we're in a 185,000 square foot new polytrauma center with 56 beds. Currently, the PrEP program has 7 inpatient beds. We're growing in the next couple of months to 12 beds. And that's because of the demand of the program. We have a waiting list of patients waiting to come into the program, much like NICO. I think that what we've realized is we've opened the box, and all of these mild to moderates TBIs have come out, and that we have a tremendous need to take care of them. So you can see this is a beautiful facility in Tampa, Florida. We have palm trees. We look like more of a Marriott hotel than we do a rehab center. We have bright windows. We have great outdoor areas where patients can come. They congregate in this area. This year, for the third year in a row, we did a full Thanksgiving dinner for the inpatients right here in this area. We're one of the only VAs that has a rock climbing wall. And you can see the beds and the facilities are stellar. They're top-notch facilities. Their hallways are wide, the colors are bright, and I'm very proud to be working there. And our staff is a phenomenal staff that's been working together for 7 years, and I welcome any questions about our program. Thank you.
Thank you. Before I turn it over to Colonel Gadson, I just wanted to comment on, we talk about the network, the NICO, Intrepid Spirit, the military health system pathway of care. Mr. Miller sort of makes a great point that this network is part and parcel with our VHA, our Veterans Health Administration Service colleagues. And there's actually 5 polytrauma centers around the country, not to mention 21, each VISN, each Veterans sort of regional network has a sort of a TBI lead as well. And so this network is more than just, as you say, it's not your father's VA anymore, it's not your father's military health system anymore. It's this nationwide network, and I hope we can talk a bit more about that in a minute. So to kind of put this all together, I'm hoping that Colonel Gadson can kind of give us your thoughts, and please have at it, sir. The floor is yours.
No, thanks. Good morning, and Admiral Collin, thank you again for inviting me to be here. I guess I'm the only non-doctor on the stage, and I don't have slides, so that must make me a training aid. Just kidding. I really like the theme. I used to be a wounded warrior. Maybe that even came across in some of my discussions with Admiral Collin. And when I think about that, when you listen to that theme, we all have a responsibility as a nation to kind of start with the end in mind. And so oftentimes we want to label us as wounded warriors, but I don't think of myself as a wounded warrior. I was a warrior and I was wounded, and that was over almost 10 years ago, and I'm not continually wounded. Now, after looking at some of Dr. Pasquina's slides, I'm a little bit depressed that I might be subject to a lot of these, I'm just kidding, subject to some of these challenges, but in reality, they're all very true, from the sleep, from the increased weight, and just essentially how your mobility has been compromised. There are significant implications that are associated with it, and I think the whole context as a nation, as we discuss our responsibility, not just from the government, not just from the military medicine perspective, but really from our communities. I've been blessed to really be a part of this whole equation as a soldier, as a former soldier that has moved on after my wounds and transitioned from the military. I was wounded in May of 2007, essentially during the height of the surge. Significant injuries, obviously some that you can see, but just the organ shutdown or organ damage, the amount of blood I received, even damage, severe damage to my right arm. Really, it's an amazing story in itself. If you want to go through my medical records, go through it. It's really kind of a miracle. But I really think it's about getting through this. As much as that technology allows us to overcome injuries that would have never been survivable in previous wars and previous decades, that's just the beginning of the journey, in my impression, and from my perspective, with respect to healing. It's really now, and I think the bar has been raised in our medical community. It's really now people are looking, surgeons on the battlefield are looking not only at just making sure that someone survives, but they're looking at their quality of life. When I was wounded, in fact, the surgeon was able to do enough vascular work on me in Baghdad to allow me to make it back to the States still with my legs intact. Ultimately, the doctors had to take my left leg to save my life, and I made the decision for them to amputate my right leg because I felt that I would have a better quality of life with the use of this prosthetic or prosthetic legs. One other point that I just want to double tap that Dr. Pasquina made is the impact of the community. 3 months after I was wounded, spent 44 days as an inpatient, and in August of 2007, I went on a outdoor program in Vail, Colorado, and I was able to horseback ride, whitewater raft, fly fish, and a number of activities. And what that provided me and my family, most importantly, was hope. Hope that I could live a productive life. And because of that, I fought, even after going through my medical boards and being found unfit, I applied to stay on active duty through a continuation on active duty program, served for an additional 7 years, was promoted again, the Army sense of humor, and I got to command a garrison at Fort Belvoir. And in between all of that, I was able to serve as the director of the Army Wounded Warrior Program. So my perspectives really span being a leader in the Army, not having much idea what would happen if a soldier was wounded, nonetheless myself, going through the healing process, surviving severe wounds, and then going back on the active duty or getting back in the full-time work in active duty as the director of the Army Wounded Warrior Program that was part of MedCom, essentially a program that was designed to support our severely wounded, injured, and ill in their transition to the civilian community and ultimately potentially their primary care, which was the VA. Again, a responsibility. It's more than saving a life and giving somebody discharge papers. We have a greater responsibility as a nation to make sure that our veterans and their families that pay significant sacrifice can still pursue their dreams. And then finally, as a garrison commander, kind of seen it at a little bit more of a macro level, being in charge of an installation and making sure that they had the adequate resources to make sure that the medical community, but also the accessibility of the installation could accommodate those that have challenges. And so that's the perspective I hope to share with you today. Thank you.
Thank you very much, Colonel Gadson. And thank you, colleagues. That's a great kickoff. Definitely, like I said, I want this to be about a dialogue and interaction with you. I was going to kick it off with the first question and hopefully stimulate some thought amongst the audience there. And please feel free to use the microphone. If you feel you can shout it out and I can hear it, I'll repeat the question for you as well. But the first question that I had is, Colonel Gadson, you kind of alluded to the idea of reintegration. And I think my colleagues here can provide some perspectives on, reintegration from a military perspective, from the VA perspective, and from the civilian perspective as well. You may say that there are some differences, and you obviously, Colonel Gadson, have demonstrated reintegration from several different perspectives. But what do you think, again, the similarities and differences are with the missions for reintegration, or what is the mission that we're trying to reintegrate folks to? And then what are some of the programmatic and perhaps technical advances, aside from the obvious that we've seen here, made since 9/11 that have made significant differences in the lives of those injured along the way?
Your question is?
It was about reintegration. I mean, do you see a difference in the reintegration mission? Again, from the perspective of the military, you obviously, and it's a startling statistic, the number of amputees, in fact, multiple amputees, who then went back not just to active duty, but operational as well.
Right. So one of my idea, and this is, I don't want to say it's radical, but it's, you know, our military recruits people to serve. I mean, we have an active recruiting process to get our best talent to serve our military, and so that's where it really begins. And I think that we have to collectively look at this with the end in sight. And so when we recruit someone and they decide to serve, we have an obligation to them essentially until, or potentially until we put them in the grave, when their life is over. So with that in mind, to me, I think there's room, there's lots of room for the handoff between the Department of Defense and the Veterans Administration. I personally believe that it's our Veterans Administration and our DOD have to do a better job of that physical battle handover. Almost like you should be recruited, like we recruited you to serve in the military, we should recruit you and make sure that you have a positive battle handover into the VA. And by doing that, we ensure that we meet our obligation as a nation to those that serve. I think there's significant room for improvement in that process. I'm not so sure why it isn't, and really the creation of the Army Wounded Warrior Program was created because of that transition was not as aggressive as we needed it to be, and some of the statistics over the years have kind of borne that. The results of that transition being poor with veterans that have fallen through the cracks. So there has been a lot of improvement that's happened there. I don't want anybody to say I'm bad-mouthing, but as I look at it, as I've looked at this over the last 10 years and been a part of it, I still think there's a lot of room for improvement.
Yeah, thank you. Go ahead, Dr. Pasquina.
Yeah, I think part of that, and I completely agree, obviously. One, because Greg is bigger than me, but there is some confusion around that topic, and what I see that it's confusing is, one, anybody with greater than 30% disability, which pretty much includes all of our wounded warriors, is eligible for DoD care for the rest of their life. Moreover, their families are eligible for care. That is not the same in the VA system, right? So you transition a wounded warrior from the DoD to the VA system, number one, they're still eligible and still should have access to the DoD system, but their families don't necessarily have that same care network because they're not eligible for the VA system. And so, I think we need to be looking at family units, not just necessarily the injured service member. And, as somebody that's deployed and spoken with many other service members that have deployed, when you deployed, what was your biggest concern? Was it your health or was it your family's health that you left back at home? And as we look at, and I didn't mean to be doom and gloom, let me just say that my wife gets on me, but Greg's an athlete, and I talk about this frequently. in your entire athletic career, now Greg, you know, was a pretty successful athlete, and I'm sure he won't talk about it, but do you reflect more back on your successes or that one play you didn't make? And I think most people reflect back on that failure that they might have rather than their successes.
Right.
I don't know if I'm a glass half empty or glass half full guy, but I think that's just a human nature. And so what keeps me awake at night is not necessarily the things that we did great, but are the things that we may have been able to do better. And so the real question is from that point of injury throughout that acute and subacute area where the DOD is really the only option, what can we do better to help with that transition, not just of the injured service member, but of the family as well? And you know, maybe Rory, you have some thoughts on that.
I certainly do. I mean, I actually think it's not only it's the DOD, it's and including the public health service, because at Walter Reed there are a lot of public health service people going around as well. We did get smart and get VA people integrated into the military very quickly.
Right.
As you know, I started coming to Walter Reed for the VA in 2001, and but also it's the private sector that needs to be involved as well.
Right.
Our active duty military and their families receive a lot of their care through the private sector, and veterans and their families as well. And I think long term we need to look at a better way to integrate all of these systems. I mean, if I were President-elect Trump, I would be looking at, you know, can we make families eligible for VA care as well as veterans eligible for VA care? And can we, you know, if you have, can you seamlessly go between military treatment facilities, VA treatment facilities, even, for example, you know, NIH has, and HHS has its own treatment facilities as well. And for people with very, you know, rare diseases or unusual conditions, which includes some of our military and veteran population and their families, seamlessly go between those systems, and then somehow know when you're receiving care in the private sector and how that comes, and how that works as well. It's a whole person, it should be a whole system.
Rory, your comments bring to mind an example of and I just say kind of a gap in terms of how our government, there's room for improvement, there's gaps. And so I served for 26 years in the Army, and I guess most of you would expect that if you serve 26 years, you'll be eligible for TRICARE. Well, while I was wounded, my spouse, my caregiver, had to stop working, and so we were on Social Security disability a while to make up for her income loss, or part of her income. And so for being on Social Security for disability for over 2 years, I found out when I went to retire that I was not eligible for TRICARE. So as a 48-year-old retiree, I have to pay Medicare Part B insurance as my primary payer. Not something I was expecting to do when I retire. So these are gaps. These are things that have to be fixed legislatively. It's the law, and so that's an example of where I see there's room for improvement.
The other thing that I'd like to bring in is that if we can look at reintegration, I mean, that really belongs to the communities. Really need to be involved in that. Because we need our not-for-profits to do that. When Greg went out to Colorado, you know, that was a program run by not-for-profits. In my case, the Paralyzed Veterans of America has been a tremendous help with. I'm part of their hand cycling team still today, and the Veterans Wheelchair Games is a combination sponsored by the Paralyzed Veterans of America and the VA. The Disabled American Veterans and the VA co-sponsor the Winter Sports Clinic, and so those ties are important. But and also employers. You know, Greg and I are working. A lot of our veterans. One of the things that, you know, that the audience should know very well is when you meet a new person. I mean, one of the first question they typically ask is, "What's your name?" and so, "Who are you?" And the second question is, what do you do? And it's really been tremendous how this generation is really wanted to be able to answer that question, like Greg answered it. That he's no longer a wounded warrior. You know, he runs his own successful business, and I'm a modestly successful researcher and professor, and actually proud to be a professor at Uniformed Services University as well. And I think that's important too. And that also is important to the family, right? Because it gives mom or dad an identity and something that their kids can aspire to as well.
Well, thank you. I think all of you allude to the fact that it's not just the service member that's injured, it's the family that's injured, whether it's the visible or the less visible wounds. And I think reintegration also is reintegrating not just the service member, but the family as well. And the startling statistics that the kids of service members, for example, with psychological health concerns, at least half of the kids themselves suffer the symptoms of post-traumatic stress disorder as well. So recognizing that it's a family affair.
We need to define family very broadly. If I could just talk about, you know, personally, when I was injured, my wife, now 35 years, was my fiance at the time, and she wasn't in the military at that time, wasn't considered family. And in my case, it was my grandparents who sort of stepped forward, and my sister. Right. And that's not, so that, I think we were good, especially in Walter Reed and in San Antonio, defining family more broadly. And that's where the not-for-profits also really stepped in, like Hero Miles and things like that, to say, well, we can only put your family on official government, you know, your spouse or immediate parents or something on official travel, but these other organizations stepping in to look at family more broadly defined. The other thing that's really important too, I saw this a lot, and Paul can probably talk about it even more, is that there's kind of an inrush of family and adrenaline when you're acutely injured, but as the rehabilitation takes a little longer, there's often kind of a lull there. And the family really needs support for that, because that's, I think, when we saw a lot of the divorces happen or people separate. And I know when my wife would go to Walter Reed with me, she would often talk to the spouses or girlfriends or boyfriends and say, it gets better. This is the dark time, and you got to hang in there a little longer, and things will get better. And we need to institutionalize that support, whether it's caregiver support or, and by the way, my wife hates the term caregiver.
Yeah, I was thinking.
She is not my caregiver, she is my wife. That you need that, you know, peer support, family support, to get people to see where that future is certainly brighter than it is at that time when they might be thinking about leaving.
Right. Mr. Miller, you see that long term. I mean, you probably see people for years. What do you see from the family perspective?
Well, you know, I better take my VA hat off for a second and put my retired Navy hat on, because I don't think this is the VA's view. I know that in our program that we do a lot of outreach to the families and that we include the families in the care that we're giving. And in the Polytrauma Center, we include greatly the families. Matter of fact, there was a child born to one of our severely traumatic brain injury patients, and he learned to walk in the wards going down the hallway. So you see the families and you see the integration, and I do think that we should, as the VA, look at that a little closer. I think our family programs should grow and become more robust. I see that. I think one of the other things, and it's not only for severely wounded, it's for every military person. It seems like when you join the military that you should automatically be enrolled in the VA unless there's some exclusionary criteria that rules you out, instead of the member having to run down to the VA and bring their DD-14 and register and go through all that stuff. If we take the other approach, that you're in the club rather than you're out of the club until you join the club, I think that would help capture more of the folks that we currently miss. we do recruiting things to go out and try to recruit people to come into the VA system. Instead of that, I think that they should do some legislative changes to embrace the service member automatically.
You know, with that point, I just, that's maybe one of my soapboxes. Again, I go back to the thought of starting with the end in mind. And if we know that, as you said, you're ultimately going to become a veteran, to me, the baseline document for entering the military ought to be what is the data that the VA would require. And then, from a data perspective, you layer on top anything service specific. Right. And then when they transition, they've already, that is already established. And to me, it just makes the most sense. But I know there's a lot of parochialness and bureaucracy that doesn't make it that simple. And I'm not qualified to say how easy it would be. But ultimately, if that's what the contract is for someone who serves our military, why aren't we starting that way?
All right, Mr. Miller, what is the number of people who are eligible for VA care who either don't seek it?
Yeah, I don't know the exact numbers. I'll tell you that, but I can tell you that there's a significant number.
I think
there's a significant number.
Patients who are eligible, they have no reason not to seek it, but they choose not to seek it.
Right. I have friends all the time coming to me saying, "Hey, you work at the VA. How do I get in? What do I got to do? Where's the eligibility office that I have to take this DD 214 to?" There's not. I mean, if we did it the other way, there wouldn't be those kind of questions.
And that's on us too. I mean, that should be known before they take this off.
Yes, it should be. It's not covered, I don't think, very well in TAPS.
Right.
I went through mine in about 30 minutes and signed a bunch of forms and went home.
Right. I think we're doing a slightly better job, but yeah. Sir, I understand your question.
Good morning. Thank you very much for coming. I'm Stuart Camel from the Extremity Trauma Center of Excellence. Dr. Pasquina, over the last 15 years, we've done, I think, a really, really good job of developing the rehabilitation programs throughout the DoD. Can you talk a little bit about the challenges right now to maintain them and what is being done to help maintain those programs?
Sure. So, first of all, what's the perspective of rehab, right? Let's just start with that. Obviously, I have a certain bias for rehabilitation, but many people saw or envisioned a paradigm where your acute medical and surgical issues were taken care of the DoD, and then all your rehab issues would be taken care of the VA system. So that just doesn't work. I mean, plain out, period, doesn't work. After an acute injury, your acute medical and surgical issues are equally important to your acute rehab and your acute behavioral health issues. You cannot wait until all the medical and surgical issues are taken care of before you start addressing the rehabilitation and behavioral health things. So you have to move all of that stuff into point of care and throughout. And there is a natural progression as to when the acute surgical and medical issues start waning and when the rehab issues become greater. But even in the ICU, you are trying to maintain muscle strength, muscle conditioning, cardiovascular training, cognitive remediation. All of those things start day one. And there's very good evidence that if it doesn't start day one, your complication risk dramatically goes up. So then, therefore, if you just accept that as a fact, as a standard of care, you need to have competent providers that can do that from the acute through the subacute stage. Finding and developing competent folks and having enough capacity to be able to do that with incoming casualties coming in on a weekly basis is challenging. And the first, and I'm sure we've got very senior officers, retirees in this audience can attest to that. The first thing that happens when the casualty numbers start decreasing from overseas is we start decreasing our number of men and women in uniform. And so it's a constant challenge to make sure that we don't lose that competence and capacity, if that makes sense. And I think Dean Kellerman's here too, so he's going to tell me don't use the term competence and proficiency, right? So we think of it a little bit different. But bottom line is we need to have providers that are proficient in providing that care. We can always expand our capacity, right? But you have to have the minimum. You can't just go from, and I talked to the inpatient folks at Walter Reed, you can't go from 0 to 40. You can go from 8 to 40. So if you're inpatient census, and I can tell you, during the height of the war, we had 100, 150 casualties in the hospital at any one time. Now we've got 10, 15, maybe 20. But you can't go from 0 to 150. You've got to have that base support. So how do you do that? I know a lot of people are looking at expanding the DoD's role, moving folks with certain injury categories to main hubs like Walter Reed, San Antonio, and San Diego. Similar model as what the Burn Center is down in San Antonio. So to try to keep that proficiency, which is very important. But it's not just the proficiency, it's actually keeping those core providers in those core disciplines that can perpetuate that. And having ongoing educational program, ongoing research program, all of that is part of it. So I don't know if I answered your question. I actually appreciate your comments on it because you
actually, Paul, if I can add to that, because I have some additional thoughts. One of them is that the Uniformed Services University has to play a key role in this. The people that have had those wartime provider experiences need to be teaching at the Uniformed Services University so it becomes institutionalized throughout the military healthcare system. So that those students at Uniformed Services University now and in the future will have been taught by you and Walt and others who were there when there were 150 casualties in patients. I also think that the National Academy of Medicine did a nice report that came out earlier this year on the lessons learned from military emergency medicine and how that is important to the civilian sector. And that the tremendous lessons learned there could help the civilian sector. I think that the National Academy needs to do a follow-up report on rehab. I don't think the civilian sector the civilian sector has not benefited from the lessons learned in the military and the VA in the last 15 years, and we have learned a tremendous amount. I mean, just in Greg's case, I mean, he would have never got to where he was if this had been a civilian injury and treated in a civilian hospital and gone through a civilian rehab program. And those lessons, one, need to be institutionalized throughout the United States. That should be the model for rehab through the entire United States system. And that will allow you to have those people when you need to go from 8 to 40 so that they're out there, right? Because they'll have been trained by people that know what they're doing, and if we can take these lessons learned and transform America's healthcare system, we can take these benefits that our service members have received, our veterans have received, and translate them to all Americans.
Just as a little point, as a patient, I think that I would be disappointed if we as a military gave back that ground. I think there's an opportunity, for instance, in again, prosthetics and all the rehab associated with it, to be a center of excellence, much like we have the burn unit in San Antonio. Maybe Walter Reed is the center of excellence for prosthetic care. So there's two things. We take in, for instance, traumatic limb loss and keep those skills up, but then you continue to develop and have the resources to continue to develop prosthetics. Because the question is not if, it's just a matter of when those kind of casualties are going to happen or when those kind of circumstances will be, and we don't want to be caught short. We were caught short, in the middle of the 2000s, not being able to address that. So that needs to be, as Roy said, institutionalized, and that is is my thought of how we could accomplish it.
I think the other thing that's important too is the research side and the translation of the research. So, it's continuing programs like the EASE and the polytrauma centers and the DIVBIC and the NICO and the partnerships between the VA, the Public Health Service, or HHS, and DOD in research and translation of research into practice is also important. I think we did a really great job once we kind of got moving of recognizing that the VA is really good at this, and DOD is good at this, and HHS is good at this, and saying, dividing up who would take the lead, and we don't want to lose that as well.
Paul, you could describe where the DOD medicine did interact with civilian medicine with the Boston bombing victims, right?
Sure. So there are, in those
some
unique
exceptions, I guess.
Yeah, unique circumstances where, individuals will be given Secretary of the Army or Secretary of Defense designation status to be able to be treated in DOD facilities. That has happened to a couple of the Boston bombing victims, as well as our relationship now with the Clinical Center at the NIH, working for individuals with cancer to be able to move across the street. And Dean Kellerman's here. He was a huge champion of making that happen. So we do believe very strongly that many of the lessons learned in both sectors, civilian and the military, can feed each other.
And Captain, I'd like to say that during our sessions that we had a couple months ago at the NICO, we discussed research significantly, and that we do have a significant amount of research going on right now, more along the lines of TBI care. I know that we're collaborating with DOD from the VA side, just in Tampa, on 42 different TBI research projects going on right now. And we're collaborating with the DOD side, and we're sharing data, and we are trying to reach out. So it's not all doom and gloom, I don't think. I think it's all that we need to create the networks effectively to share the information and share the data and improve on what we have now.
If there's any, the horrors of war over 15 years, there's never been a generation that's basically lived in a generation at war. If there is to be a silver lining, it's the fact that many of us have spent a career with our country at war. It's not been a 2-year, 3-year, 5, or even 10 years. It's been a career. Yeah. So I'd like to think that has perhaps institutionalized some things, but we know that memories sometimes are as short as a career or a tour length. I don't know, Dean Kellerman, if you're going to comment on the National Academy of Arts, Science, and Engineering initiative to incorporate civilian and military trauma systems, but to sort of capitalize on the gains made in trauma care over the last 15 years by the military, translated to the civilian world. What happens when activities, contingency activities decrease, our throughput of patients to the military healthcare system diminishes. How do we then leverage what the civilian sector has learned and then continues to practice to continue to keep the skill sets up for the military providers? And
Art Kellerman, Uniformed Services University. Thank you, Walt. You set that up perfectly. I did want to tie 2 or 3 quick strands together and ask for comment. Rory, I love your idea about rehab and military involvement in rehab in partnership with the civilian sector should be as emphatically emphasized as the NASEM report did for trauma. It is trauma care. It's just trauma care at a different point in that continuum, as Paul so eloquently expressed. I would suggest, speaking as an individual, not on behalf of the U.S. government, that I don't think you have to wait for another report. I think you and Greg could collaborate and write a very powerful essay for the Washington Post or the New York Times or to the Politico, and it would get into Congress much faster and possibly more powerfully than waiting for that report. Paul, you just described the Boston Marathon couple, Patrick Downs and Jessica Kinski. I think some folks in the room know there was a very powerful HBO documentary recently called Marathon that I thought the most potent parts of that documentary were their work with wounded warriors at Walter Reed and the team push that helped them improve. Is there a place for the military and rehab. If we argue going forward that there are certain military treatment facilities like San Antonio today that are in the community trauma system, might we not also take that idea from Patrick and Jessica and say there should be military rehab facilities that are available to civilians, particularly civilian victims of terrorism? Might that be an avenue to help maintain proficiency and keep the capacity in place for when we might need it in the future? That's not true today, but it might be true in the future with some enlightened public policy. Any comments from any of the five of you?
I personally think that's a great idea. I think BAMSI, the Burn Center, has demonstrated that that's been an excellent idea to help the civilian sector, the VA, and the military population. And it's served them well, nearly since the Vietnam era. And not only has it served the people that have been treated for burns there, but for the entire field of medical care for treating burn patients. I was flabbergasted. I actually did a speech in Germany a few years ago, and I think that people thought that I misspoke when I talked about the success of the burn centers and the amount of burns that people could have and survive. And I think we have that same opportunity with trauma care, trauma rehab and other trauma care, areas of trauma care in the military. The other thing that I think we want to lose touch of is that we have a large proportion of our military healthcare providers are actually in the reserves. And so those, and in the VA, we have the academic affiliates as well. So they use those ties between academic medicine and the VA and academic medicine and the military, even though it's not necessarily formalized, because we don't necessarily think about our reservists being in the academic part of the time and in the reserves the other time. But I think formalizing those relationships as well, because we have those already in some ways have those civilian ties established.
Do you think there's a hesitancy because people just don't think it's allowed? I mean, that there's legislation that prevents that kind of cross-pollination between the public and the private sector? I mean, I think you're the exception, well, at least a very visible exception, Dr. Cooper, with your close collaboration between UPMC and the Pitt VA, the Pittsburgh VA, but also you're on faculty at Uniformed Services University, and you've got a very close collaboration with DoD. Can that not be a model that others say, well, if he can do it, what,
I would hope so. I mean, I don't want to be the only one. I'd like to be one of thousands. And I do think that's an opportunity. And we, after World War II, Omar Bradley and Paul Magnuson, they got Congress to make the Title 38 to allow academic affiliates, allow VA, certain classes of Title 38 employees within the VA to have appointments at academic academic institutions and not consider that a conflict of interest. Frankly, I think we should take this opportunity to have maybe the next Secretary of VA, or the current one if he's really fast, to extend that to DoD as well, right? So you can have DoD academic affiliates and you can have DoD personnel. And then also I think they need to take the barriers down between Public Health Service, VA, and DoD providers being able to move within those systems throughout their career in a more seamless manner.
In a much smaller program, I believe as part of the Special Forces Medics Training Program, they actually travel and ride with paramedics in some of the local fire departments, I think in San Antonio and maybe up at Fort Lewis, because again, the kind of medicine that they've got to practice on the battlefield, those aren't rolling in, and so you need to be in a large area where you have victims.
And we did that a bit in the 2003, 2004 timeframe. A lot of the trauma surgeons in the DoD facilities would go to the larger cities and work in those trauma clinics for 3 or 4 weeks. I remember some kind of pre-deployment rotation in order to get their skill set.
Yep. heard that exact thing last night. Is Colonel Mabry here? He described that Special Forces medic before he went back to medical school. Some of his best training was out on shift with the paramedics out in town. Colonel.
Gary Peismeyer, Wright-Patterson, commissioned in about 2000, and pretty much my entire career has been in a nation at war. Not a comment or a question, but a comment. And as someone who's deployed multiple times as a trauma surgeon, sometimes we would save folks with terrible, grievous injuries and kind of think, well, what's next? I mean, what does this person really have to live for? And on our weekly teleconference with the JTRC, every other week or so, we would get something from Tampa that this person who was injured 3 years ago with horrible things has had multiple operations and finally has turned the corner into doing a productive life. And I think that's a comment that we don't give up on our people. And for the people that aren't injured or the people that are taking care of the ones that are injured, it gives us hope that there is a life after these injuries, and the fact that our rehab folks are working so hard to make these people have a quality of life that's acceptable. I think kudos for all of you for what you're doing.
Thank you.
Thank you. I'd like to comment on, I know from the time that I was the Deputy Marcen surgeon down in Tampa from 2009 till I retired in 2014, I would go to the Tampa VA with Dr. Scott and sit there, and we would join in the Joint Theater Trauma call. And then many times at the end of those calls, he would be asked about cases, and now he's continuing on with that and presenting cases, like you said, from 2 or 3 years out. And you can see the outcomes of some very severe injuries, and that these patients do very well. And I commend my boss, Dr. Scott, for continuing on doing that. So thank you very much, Colonel, for that comment.
Yeah, if I can just add to that comment, and I probably shouldn't, but I completely agree. Those calls fed into a quality improvement project across the trauma theater system. I can only say from my perspective, I tried to call in those weekly calls, but I can tell you at Walter Reed, we were at any one time always 10 to 20% staff shortage to try to meet the mission. And just making that call once a week became almost impossible. And so, General Franks, it's kind of interesting, you run across, you have the great opportunity to meet, amazing individuals. But General Franks said, when he was staffing his line and his combat troops before going into theater, before going into battle, he always had a 10% increase in staffing, because he knew with people coming and going, you were always going to lose 10%. So he made this huge argument that he did be 10% overstrength. Yet in the medical environment, when he told me that, I was like, oh my God, we're always 10% down, and in the summers we're 30% down, and that's when the highest number of the casualties come in. So I can tell you that there are huge challenges in trying to meet that. But obviously, thank you for the lives that you've saved and all your trauma colleagues. Without that, it gives us nothing to work with, right?
If I can just tack on to that, pile on as it is. I can appreciate the sort of the warm response if it's surgeon to surgeon, rehab to surgeon. I have a tremendous respect for other members of the team who could easily be making those calls as well, and case managers, social workers play a huge role in the program that I oversee. It's great for me to talk to my like-type counterpart who referred the patient to me, but it's my case manager and the social worker who will set up all those referrals when I make my recommendations. Likewise, I think having that feedback, whether it comes from Dr. Pasquina or Sylvia Massetti or whomever the case manager is following that patient, I think is huge. And to your point, sir, I think it gives hope not just for the for the caregivers, for the families, but for the surgical team themselves who might start to question, what is this person's future going to be? I think that's just huge.
I also think some of the not-for-profits that have made it possible for people, once they've been wounded several years later, to go back and visit Launch Tool or go back to one of the trauma centers has been a tremendous benefit as well. Even though the same team may not be there, you just get to see people down the line and talk with them and see that life is that they have a good quality of life. And
you know, actually, when you think about it, part of the redeployment or post-deployment transition for the trauma team might be, you know what, on your way back home, just stop by Walter Reed a couple of days and see guys, you know, that are back to running marathons or doing various things. That actually wouldn't be a nice way to, you know, institutionalize that process.
Or see a VA polytrauma center too.
Yeah,
a lot of people don't necessarily
Walter Reed is just an example, sure, yeah.
Have a good understanding of what the VA's capabilities are. I loved your, you know, the pictures you showed that, you know, the VA is not your grandfather's VA.
Sir.
Yeah, thank you. First of all, thank you for being the warriors that you are, and I believe that all warriors, to some degree, have a handicap, whether it be a wheelchair, wearing eyeglasses, or a hidden disability. It's gone. So consider this, that in the private sector, almost always they look for customer satisfaction. And they spend millions of dollars to do so. And I was amazed at what Commander Miller had come up with. 90% is considered terrific. 100% satisfaction, there's got to be a secret to that. And I believe that a lot of it has to do with house calls. In the old days, doctors did house calls. There was that relationship that, like, you respected your patients, you lifted them up, you were so important, I would leave my family to see how you're doing. Commander, how the hell did you do it?
It's, you know, the day in, day out, I think the care that the team provides and the trust that's built between the special operator and the team has been incredible. Their trust in our providers is built, and from day one they come in very skeptical, and you know, on day 50 or 60 when they walk out the door, they have a whole nother perspective of what's going on. And it takes a city, it takes the team to sit down and work with the patients one-on-one. I know I spend a lot of time from a military perspective sitting down and talking with our patients one-on-one. So it's, I'm not saying that they're 100% well, they're 100% better when they walk out the door. And I think that's phenomenal. And for all of them to fill out the surveys and say that, I think it's an attest to the team and the program. And I'm really glad that we're able to grow this program a little bit bigger from 7 beds to 12 beds so we can take care of more folks. And I know that's our goal we share patients, we share information, and I think we all want to do what's best. When we scratched the scab off the wound, I think we realized that there's a lot of mild to moderate TBIs that are out there that aren't getting care. Hence, I have a pretty long waiting list waiting to come into our program in Tampa. I know that you have a waiting list, sir.
There's a lot of demand, yes, sir. There's a lot of demand out there.
But I think a lot of the success in Tampa has to do is that those healthcare providers share the same core values as the patients that they're treating.
Yeah.
I also feel that, you know, as a family physician, and I know it's not unique to family medicine, I've often heard that one of the things that we've lost in this generation of clinicians, not just family medicine, is we've lost compassion. And I personally don't think we've lost compassion. Dean Kellerman, I sit on the admissions committee for the medical school, and I see admissions packages with just genuine compassion. I mean, these are kids coming in just chock full of compassion. I know they have it, and they don't lose it somewhere along the way. They don't lose it when they go to war. In fact, I think if anything, they gain it. I think what we've lost really is the time to spend with the patients. I think it's hard to show compassion when you've got a 10 or 15-minute appointment. We talk about the resources to take care of our injured colleagues. Isn't necessarily the $5 million MRI machine. I don't think getting an MRI increases patient satisfaction. It's that resource of time that we get to spend with those patients. And I think that if there's anything we're going to try and improve, it's the amount of time we get to spend with our patients, not putting them on a timeline. And granted, that may require sort of a reconfiguration of what is the value proposition for what we do. And understanding that the time that we spend with a patient really gets that compassion across. And I think that's where patients really feel the value of the service that they're getting is the compassion that comes across by developing that relationship with their clinician, not just their physician, but their physical therapist, their nurse, their corpsman, and really the compassion then that's shown to the families and those that they love the most as well. Ma'am.
Hi, thank you for being here. And I want to say that I was tremendously excited about the title of this panel presentation. I used to be a wounded warrior. I'm Lieutenant Commander Gail Tarleton. I am in the U.S. Public Health Service. I've spent about 4 years in private practice, neurology. I've been in the NIH for more than 5.5 years. Working in neurology fields. I've never had the opportunity, the privilege of treating our warriors, but I have had a lot of experience with patients that have various types of brain insult from different mechanisms. And what I was excited to hear was your statement that I don't consider myself a wounded warrior anymore. I have moved past that. It's part of who I am, but it doesn't define me. That's not my title. And what I've seen in people who are successful in their recovery is a quality called resilience. And it's a very complicated sort of variable. We don't know if this is something that can be taught. Is this a genetic basis that some people have, some people don't have? So we've talked a lot, or you've talked a lot about systematic things to help improve the process. We've, piggyback on the adage of you can lead a horse to water, but you can't make him drink. We've created it's evolving, a wonderful system of recovery for our warriors, physically and emotionally, through that. PTSD and TBI as well is huge. But how do we get them to drink? We don't have every soldier, sailor, airman come through the system and want to engage. And we get a lot that are lost in that follow-up. Should we be looking at resilience in the early part of this process prior to going into the theater? Is this something that we should research or learn how to teach to people before they find themselves in these positions? So trying to shift, maybe a little bit away from a systems thing to say, I think we need to capture the quality of resilience and infuse this into the system so that we have even greater outcomes and people no longer consider them wounded warriors. They are people.
Sure. Well, I can, again, speak briefly about my perspective from the TBI and psychological health realm, and it's more anecdotal than based on sort of a broad scope. But the patients who come through our interdisciplinary program, again, they're hit with a lot when they're there. You saw the list. The things that they sort of described as being the most beneficial to them were really kind of the high-touch aspects of things. The mind-body wellness, the meditation, yoga, art therapy, the creative arts therapies. Yeah, they're getting, the $1 million workup with MRI and MEG and things like that, but it's the things that they say, man, if I'd known this 10 years ago, I probably wouldn't be here where I am now. And that, to me, speaks to resilience. If they'd been taught some of these tools, because a lot of these tools are things that they can then take with them and practice on their own. They don't necessarily need a clinician to follow up with them for some of these things. And it kind of speaks to resilience, and sometimes they'll actually say resilience, and sometimes they don't necessarily. I think it was Mr. Miller who referred to the special warfare community and how they seem to be able to take a lot more abuse before they sort of raise their hand and say enough is enough. I don't know that that's necessarily an indication of them being more physically tough or have learned more about resilience early on, or they're just that sort of phenotype that are resilient before they even go in. That's why they go into that sort of line of work. But even they will come back and say, if I'd learned some of these tools to help build some of my resilience, I think that would have made a difference. So I do commend that question, and I wonder for my colleagues if you recognized anything aside from maybe what you learn in boot camp or in officer training.
Well, I believe it was under the Army CF Comprehensive Soldier Family Fitness Program. We started, the Army started teaching resiliency training right in basic training. And so there is a recognition that resiliency can be taught. My old boss, General Schoolmaker, used to say that there's 10% of the people that you can leave them alone and they're going to figure it out, and there's the other 10% that no matter what you do, they're not going to get there. And so what we got to fight for is that 80% in the middle, that we can teach resiliency, we can make a difference in their lives through that. And so as I think about my resiliency, I'm I didn't go through any formal resiliency programs, except I think that as being an athlete and getting knocked on my butt and getting up again. But there are lots of ways. I think about Corporal Josh Blau, who was a Marine corporal, and I was a lieutenant colonel who I looked up to, who had similar injuries than me 6 months prior. And he became my pace man. He became the object of my hope in such a way that I began to create expectations based upon the progress that I saw him making. And so it can come in many shapes and forms, and I think it's very valuable for us not to discount any of those possibilities, because you never know what can excite someone to recover. But it's not it's not like a silver bullet. It's not a single shot. It's got to be sustained, because that's how you learn. That's how it's taught, over a sustained process, and not a 1 week class or 1 hour class or whatever. I think there's skeptics. There's skeptics from guys like me that, are on the tactical side and don't believe in it. And I think there's skeptics in the medical community that don't believe that, that the answer can come from within someone as much as from an operation or from some pill. So
I also think it comes from a command standpoint. I think resiliency, I think, starts in the command level. And if your command believes in the principles that you have there, I think that your people that work for you are going to be better. I know I've taken care of many of folks, particularly with the Marine Corps and Special Ops, that the commands are really great, and they're concerned when they fall off the edge. And we get them when they fall off the edge. The key is that at the command level, I think we have to do better and more education there to keep them from falling off the edge. And and as they downsize some of the forces, I think it's hard for the commanding officers to grasp all of that and then realize the resiliency really starts at the deck plate with the command level.
Great. Some of what you're describing is mentorship. Creating a positive atmosphere for very strong mentorship, not just before, but also after, to say, I've been through this, I'm resilient, this is the way to be that way. So thank you very much.
Thank you.
So I think Paul and then I think Greg picked on this too, at putting people through in cohorts. Right, so that in my case, I had Tim Davis, Marine corporal, injured in the Tet Offensive. He had gone through rehab, had a job in the community. He actually walked me through the VA and those sort of things, and that really helps a lot. But it's just like, the team sports. So you have to have these cohorts you have that capacity. So you could have amputees going through in cohorts or spinal cord injury in the VA in cohorts. But you should be doing this resiliency training in cohorts. The other thing I don't want us to miss before we leave the stage is we can learn a lot of lessons from our international partners. We don't go to war anymore as just the United States. But we've got Germany and France and the UK and Australia and Canada and many other countries by our side. And they're learning these lessons too, and we need to share them together. And the Invictus Games is an excellent example. The Warrior Games are in some ways an outgrowth of the veterans programs, and the Invictus Games is an outgrowth of the Warrior Games. And
Yep, the Karen machine from
the
the Israelis, right?
Karen machine, the Rewalk, or other things that are, we fight as an international coalition, and we treat people. And Paul, we've treated people from Georgia and Ukraine and other countries as well. So we have those lessons to learn and to share.
Great, thank you. Well, as we sort of wind down with time, maybe for one more quick question, I just want to sort of mea culpa my own gap analysis for this panel, and I think it would have been a great part of any one of our discussions, but especially in resilience, was to have the perspective of a family member as well. We've done studies, and I think it's well known that those that identify closely with family or with a team, again, looking at special warfare, but EOD and other sorts of very sort of team-oriented communities, on a whole, have fewer incidents of post-traumatic stress disorder and other psychological health concerns. And we've actually kind of shown that again, of all things, in some of our analysis of some of the art therapy masks that well over 1,000 of our patients at the NICO have produced, that those that identify with teams and have team insignias incorporated into their mask designs, on a whole, have a far lower, statistically significant, lower diagnosis of PTSD. Sir, you got the last one.
Good morning, gentlemen. Thanks a lot. Colonel Andre Pippin, commander of the MEDAC in Japan. Paul and Greg, great to see you. Hey, Greg, I have this question for you, and I guess it's ironic you would talk about the Marine Corporal. You actually introduced me to him when I came to visit you in the Malong House back in the summer of '07. I know you're very busy. You go around as a motivational speaker, but do you get an opportunity to get out to wounded warriors and tell your story? Because you definitely have a lot to tell, unique situation. You still got folks in the Intrepid House. I know the president was there this week. Do you get an opportunity to get out to wounded warriors, just tell them about your situation?
I sure do. I think essentially as part of my personal charter and retirement, I have made it a priority to continue to be a part of my community, the veteran community, the disability community, the warriors that's been wounded community, and so whether it's through a nonprofit, through fundraisers, or visiting VAs, I've been to probably 4 or 5 VAs this year: Seattle, Syracuse, Orlando, Dallas. And so, again, I make time for it, and it's important. As I believe, it's to share, but it's also to inform and educate, and that's one of the primary reasons why I'm here today, because I want to make sure that we continue to inform and educate. So it is one of my cohorts, and we're cohorts too, and so it is, and it's not anything that I advertise in particular, but I look for opportunities, or they find me to be able to share.
Well, a couple of weeks ago, Paul and I were at an event with Bob Woodruff. We did a nice documentary on military medicine beyond the battlefield. But I liked really one of his comments, and he said, through his experience in Bethesda and his connection to the military community and the veterans community thereafter, he found that he never realized as a reporter, as an American citizen before, that the lifetime commitment to selfless service among our military and our veteran population.
Yep. Yeah, I was just, literally last night, I was telling Rory this morning, but Chad Hennings, former Dallas Cowboy, and Rocky Byer, former Pittsburgh, you know, we were able to participate in a Salute to Veterans program that again focuses on veterans. You know, Rocky Byer, of course, was wounded and went on to be a part of 4 Super Bowl champions with the Pittsburgh Steelers. And we had an event last night at the Library of Congress. And so we actually got to have our own personal stories documented in the Library of Congress, and then we had a screening of the program last night. So again, it's I can't explain why I'm involved, but I feel very privileged and blessed to be able to continue to share my perspectives.
Great, thank you, Gag. Well, I was mistaken. By all means, Admiral Cowan, you have the last word.
I have about 7 questions. Unfortunately, I'm not going to be able to ask them because we've used our allotted time, and so I have to be the hook instead. But on behalf of everybody here, I want to thank you all very much. This has been really illuminating, an exciting conversation, and as I hoped, it put the human face on all of the things that we try to do for our patients. And so I want to lead us in a round of applause for you.
Thank you.